the introduction of who are the drugs, who are the leading players in this scenario. This talk is going to be given by Dr. Dhanya VS, Associate Professor of Ophthalmology, Government Medical College, Ernakulam. Welcome her for a very charming presentation.
Good morning, one and all, and many thanks to KSOS Scientific Committee and Dr. Sindhu for giving me this opportunity. So let us move on to the topic for discussion today, drug toxicity, who are the lead players. Systemic drug-induced ocular toxicity is on the rise as vast number of new drugs are being introduced in medicine. Any drug can cause ocular toxicity. Fortunately, only a minority causes significant adverse effects. Reports of the drug-induced ocular toxicity should be very well documented, and other causes of these side effects must be ruled out to establish the causality. Responsibilities of the physician. The physician should be aware of the potential adverse ocular reaction, and he should inform the patient about the possible risk of their use. And they should also educate them to seek medical help when the symptoms of toxicity occurs. They have to do a baseline visual evaluation before the treatment and also to screen the visual changes periodically for the early detection of the problem. So who are the lead players? Let us discuss about that. And systemic medications play a very significant role in any eye disease, and important to identify the high-risk medication and constantly monitor for the development of any complications. So it is imperative for the ophthalmologist and the physician to work together and go hand in hand for the common goal. What are the common drugs which causes ocular toxicity? Chloroquine, HCQ, ethambutol, topiramate, bisphosphonates, systemic steroids, amiodarone, tamoxifen, erectile dysfunction agents, to name a few. So let us see the name of the drug and the other ocular side effects they produce. Topiramate, as you all know, this is an anticonvulsant drug, causes bilateral acute ankylosing glaucoma. Chloroquine, HCQ, causes bullseye maculopathy. Tamoxifen, given for cerebrats, can result in crystalline maculopathy. Systemic steroids, we are giving it very commonly, and this leads on to posterior subcapsular cataract. Ethambutol, rifampicin, chloramphenicol leads on to toxic optic neuropathy. Vigabatrin, again an anti-epileptic drug, can result in progressive permanent bilateral concentric visual field defects. Sildenafil and vardenafil erectile dysfunction agent can result in non-arthritic AION. And bisphosphonates given for osteoporosis can lead on to acute anterior uveitis, scleritis and episcleritis. Amiodarone, an antiarrhythmic drug, can result in Waters keratopathy, bilateral AION and anterior subcapsular cataract. And anti-diabetic drugs like rosiglitazone and pioglitazone can result in macular edema. And a few more, digoxin, which is commonly used by the cardiologist, can result in decrease in the intraocular pressure and red-green color blindness. And antidepressants can result in decrease in the accommodation, cycloplegia and dry eye. Statins, again commonly used drug, can lead on to extraocular muscle paralysis, ptosis and diplopia. Isotretinoin, widely used by the dermatologist, can lead on to VIH, papilledema, retinotoxicity. And other drugs which can result in benign intracranial hypertension are OCP, sulfa, vitamin A, tetracycline, phenytoin, nitrofurantoin, steroids, to name a few. So let us move on to the drugs which affect the specific parts of the eyeball. Those which affect the tear film, which leads on to dry eye, are antihistamines, beta blockers, diuretics, niacin, OC pills, antipsychotics, and isotretinoin, which leads on to meibomian gland dysfunction. Next, those affecting the conjunctiva, which can result in the reversible conjunctivitis, include anti-anxiety drugs like diazepam, alprazolam, phenytoin, carbamazepine, isotretinoin, COX-2 inhibitors, and pamidronate and alendronate. Those which affect the legs include corticosteroids, which leads on to PSC, and later anti-subcapsular, which is more commonly seen in children, chlorpromazine, yellowish brown granules, and ASC, amiodarone, busulfan, gold, allopurinol, desferrioxamine, and ecolinesterase. All these drugs, the dosage and their effects will be dealt with by my fellow speakers. Drugs which leads on to uveitis include rifabutine, which causes acute anti-uveitis, bisphosphonates, pamidronate, alendronate, and cidofovir, which is given for CMV retinitis, again leads on to vitritis and anterior vitritis. Those drugs which affect the retina are anti-malarials, which leads on to bullseye maculopathy, phenothiazine, tamoxifen, crystalline maculopathy, methoxyfluoride, interferon alpha, nicotinic acid, steroids, and rosiglitazone and pioglitazone, which leads on to macular edema. And those which leads on to optic neuropathy include ethambutol, INH, amiodarone, vigabatrin, estrogen, progesterone, which leads on to again optic neuritis, and the sildenafil, vardenafil, non-acrylic AIOL, and linezolid, which causes reversible toxic optic neuropathy. Stevens-Johnson syndrome, as you all know, any drug can result in Stevens-Johnson syndrome, but the common drugs include phenytoin, carbamazepine, phenobarbital, lamotrigine, then allopurinol, penicillin, sulfur drugs, and erythromycin. Rare side effects, extraocular muscle palsy by these drugs, and nystagmus by lithium, diplopia, ptosis, and pseudotumor cerebri, and floppy iris syndrome by tamsulosin. So the take-home message of my talk today is the adverse effect profile of each medication is being evaluated according to the WHO Causality Assessment Guide. It is the role of all healthcare professionals to detect, treat, and educate the public about the adverse reactions to medications, as they are an important health problem. And it is also imperative for the ophthalmologist and the physician to work together for this common goal. Thank you.
Thank you, madam, for that crisp compilation.